experiences in advanced colorectal cancer in this 20-minute or so. So I will try to concentrate in positive trials and advanced colorectal cancer, as we have a lot of trials. So just concentrate in the main important trial, going through introductions, then a first-line setting, followed by sequence of treatment options, followed by salvage therapy. So as we know that colorectal cancer is a very common malignancy worldwide, and is based on the WHO report on cancer published earlier this year. It is the third most common malignancy in male and the second most common malignancy in female. And combining both sexes together, it is the third most common cancer worldwide after lung and breast, and the second leading cause of cancer-related death, unfortunately, after lung cancer. And so Saudi Arabia, we are a part of this big world, and our data are matching the worldwide data, and it is the most common malignancy in male and the third most common malignancy in female after breast and thyroid cancer. So in colon cancer, we have the luxury of so many options, and our job is how do we personalize therapy as the backbone therapy for many years, 5-FU oxaliplatin irinotecan in different combinations with addition of EGFR or VEGF, and we have 3 VEGF therapies. And for salvage or more after third lines of therapy, you have TAZ and regorafenib, and also for special populations, we have BRAF inhibitor, MEK inhibitor, NTRK, and anti-HER2 therapy, and definitely you have immuno-oncology therapy for first line or subsequent lines of therapy. So what influences treatment choice in metastatic colorectal cancer? It's based on many factors. The most important one is patient characteristics based on his comorbidities, prior adjuvant therapy, age, performance status, and also molecular characteristics. We have to check RAS mutations, BRAF, MSI high, and HER2 therapy to target and personalize therapy based on this molecular genetic profiling. And also tumor characteristics and our goal of treatments, if a tumor is resectable or not resectable, and also tumor locations and patient preferences based on toxicity profile and quality. And just this slide show you that why first line matters, because number of patients diminished from line to line. So as you can see here, only 53% of patients who receive second line, and 28% who receive third line, and only 13% who receive fourth line or more. And the median survival increased with increased line of therapy. So patients should be exposed to all active and approved agent during treatment as long as is set for therapy. And we are reaching more than 2 years median overall survival with 3 or more lines of therapy with a significant p-value. I will start with a patient with MSI high mismatch repair deficiency, as this was presented recently in the ASCO, and these population represent only 5% of patients. But nowadays we have very strong evidence that they should be managed differently than others. So Keynote 177 was presented in ASCO 2020, which is pembrolizumab versus chemotherapy for MSI high mismatch repair deficient. It is a randomized trial for chemotherapy for treatment naive patients, randomized to pembrolizumab 200 milligram Q3 weeks versus investigator of choice chemotherapy with dual primary endpoint, including progression-free survival and overall survivals. Baseline characteristics were similar in both groups, as we can see here. And the final analysis for progression-free survival showed the median BFS was 16.5 months in pembrolizumab arm compared to 8.2 months in chemotherapy arm, with a hazard ratio of 0.6 with a significant p-value of 0.0002. And the subset analysis showed the benefit is occurred in most of the subset of the patients. The objective response rate was 43% in pembrolizumab arm and compared to 33% in chemotherapy arm, with 11% of patients achieved a complete response in pembro compared to 4% in chemotherapy arm. The duration of response was not reached in pembro compared to 10.6 months in chemotherapy arm, and the toxicity profile was manageable, and it showed no deviation from what we know from the immunotherapy toxicity profile. So in conclusion, for KEYNOTE-177 trial, that pembrolizumab should be a new standard of care as first-line therapy in patients with microsatellite instability high or mismatch repair deficient metastatic colorectal cancer. We move to patients with RAS mutated populations. They are accounting for 50 to 55% of patients, and we know the options of treatment in this patient is FOLFOX or FOLFIRI with a VEGF antibody. Based on many trials, this is a randomized phase 3 study in 16966 trial, compared FOLFOX or XELOX with or without bevacizumab, and showed that addition of bevacizumab to oxaliplatin-based chemotherapy improved the progression-free survival with a hazard ratio of 0.83 with a significant p-value and trend for overall survival. Comparing oxaliplatin versus irinotecan backbone of therapy with bevacizumab was compared in phase 2 Maverick trial, and showed that first-line FOLFIRI bevacizumab and FOLFOX bevacizumab has comparable BFS and overall survival. Cairo 3 trial is very important trial, which compared maintenance capecitabine plus bevacizumab versus observation in metastatic colorectal cancer in patients who received 6 cycles of XELOX bevacizumab chemotherapy and achieved stable disease or response after the 6 cycles. And it showed that patients on maintenance therapy with capecitabine plus bevacizumab after 6 cycles has effective response and superior progression-free survival with a hazard ratio of 0.4 with a p-value of 0.001 with a trend for overall survival. We'll move to RAS wild type microsatellite stable metastatic colorectal cancer in the first-line setting. I will not go through all of the studies we have, but we have at least 5 studies. This is 3 of them: PRIME trial, OPUS trial, and Capecitabine trial, comparing panitumumab or cetuximab with FOLFOX or FOLFIRI chemotherapy. And as you can see here in this very busy table, the benefit was found only in patients with RAS wild type or no RAS mutation, but there is no benefit was found in patients with RAS mutations. So does anatomical side matter for in patients with RAS wild type patients? As we know in the last 5 years or so, that the sidedness play a major role in deciding treatments. And that's because the molecular heterogeneity is different by sidedness, and this mutation is not random. As we know that in the right side, they have more MSI high, more KRAS, and more BRAF mutations, in contrast to the left side, where they have TP53 mutation, ABC, and KRAS, but the most important thing, they have high EGFR ligand overexpression. So FIRE3 trial show us the effect on locations on BFS and OS for FOLFIRI plus bevacizumab or cetuximab, And you can see here the benefit of cetuximab is shown only in the left side with improvement of overall survival with a hazard ratio of 0.63 with a significant p-value. But there is no improvement in progression-free survival, but I think the most important is overall survival. Also, in CLGB trial, FOLFIRI or FOLFOX with bevacizumab or cetuximab. As you can see here now, the benefit of cetuximab in the left side, 39 months, and only 13 months on the right side. And if we combine all the trial together, we see the benefit of cetuximab only in the left side, and the right side they benefit from bevacizumab. BRAF mutation, they are special populations. So I will go to the first and second line for BRAF patients. They comprised of 8 to 10% of patients. And maybe the standard of care for this population is FOLFOXIRI plus bevacizumab based on trial. And the subset analysis of these patients for BRAF mutation positive populations, for those who received FOLFIRI plus bevacizumab versus FOLFOXIRI plus bevacizumab, showed the median overall survival is 19 months, and FOLFOXIRI plus bevacizumab compared to 10.7 months with a hazard ratio of 0.54. In the second line for BRAF populations, we have this study was published last year in New England Journal of Medicine, Beacon CRC trial, which compared BRAF inhibitor, MEK inhibitor plus cetuximab, randomized to 665 patients, randomized 1:1:1 ratio to binimetinib plus encorafenib plus cetuximab versus doublet versus investigator of choice chemotherapy, with the primary endpoint overall survival and objective response rate for triplet versus control, with secondary endpoint overall survival for doublet versus control. And the primary analysis for this trial showed that the median overall survival is superior in triplet versus control, 9 months versus 5.4 months. And for the doublet also is the similar result, shows the median survival 8.4 months versus 5.4 months, with a significant hazard ratio and p-value for doublet or triplet therapy. Anti-EGFR with chemotherapy without BRAF or MEK inhibitor was analyzed in meta-analysis for BFS and OS, and showed anti-EGFR therapy did not increase benefit of standard therapy in patients with BRAF mutant colorectal cancer patients. We'll move down to the second line. We'll start with RAS mutant metastatic colorectal cancer. So what factor in choosing the second line treatment for this population? So prior treatment with VEGF or EGFR inhibitor, progression within 6 months or prior on VEGF inhibitor, if received prior VEGF more than 3 months after maintenance, and molecular genetics phenotypes, including MSI, BRAF, and HER2 status, toxicity considerations, and also most important, patient preferences and ECOG performance status. So giving VEGF inhibition after progression on bevacizumab was studied in 3 major trials. The first one is TML study, 820 patients randomized to bevacizumab and chemotherapy versus chemotherapy alone, and showed absolute benefit of 1.4 months, 11.2 compared to 9.8 months, with hazard ratio of 0.82 with significant p-value. The second trial is VELOR trial, 1,200 patients compared FOLFIRI plus Percept versus FOLFIRI versus with placebo, and showed similar result with absolute benefit 1.4 months with a similar hazard ratio and p-value. The third trial in this patient populations is RAISE trial, which compared FOLFIRI plus ramucirumab, FOLFIRI versus placebo, and also shows the same results with absolute benefit of 1.6 month gain in survival with similar hazard ratio and p-value. We'll move to refractory RAS wild type metastatic colorectal cancer. Those who are not treated with Bevacizumab or Cetuximab in the first line. We have ASPECT phase 3 trial, which compared patient with KRAS wild type, 1,000 patients randomized to Bevacizumab or Cetuximab with primary endpoint overall survival, and showed that Bevacizumab was not inferior to Cetuximab in this patient populations with a median overall survival of 10 months.
Dr. Hashem, you have 40 minutes.
Okay, we'll move to salvage therapy. I'll try to be short here. So the first trial is regorafenib for patients who failed the previous lines of therapy. A patient randomized to regorafenib versus placebo, and it showed that there is improvement of overall survival with a hazard ratio of 0.7 with a significant p-value. Also, it met its primary endpoints for progression-free survival. In the regorafenib study, they found that the overall survival is correlated with hand-foot syndrome. Patients who develop hand-foot syndrome, they have better overall survival compared to those who did not develop hand-foot syndrome. Other options we have for those patient population is TAS-102, was tested in the resource trial, randomized trial to TAS-102 versus placebo with primary endpoint overall survival. Also, it met its overall primary endpoints with median overall survival of 7 months compared to 5.3 months with a hazard ratio of 0.68. And also met its primary endpoint for progression-free survival. For patients with anti-HER2 therapy, we don't have phase 3 trial, but we have phase 2 trials, 2 important phase 2 trials. Pertuzumab plus trastuzumab for HER2 amplified metastatic colorectal cancer in my pathway trials showed that patients treated with HER2 doublet therapy had objective response rate of 32% with complete response in 1 patient and partial response in 17 patients. And exploratory analysis for PFS and OS showed the benefit is only in patients with KRAS wild type. Another important trial for HER2 patient is patients Heracles trial, which is open label, a multi-center phase 2 trial for patients with KRAS wild type HER2 positive, treated with trastuzumab and lapatinib, and also showed objective response rate of 30%, complete response in 4% of patients, and partial response in 26% of patients. So, in conclusions for my talk today, that in first-line therapy, it is very highly effective. So the question of the best treatment sequences has to be answered. RAS, BRAF, and MSI high have to be revealed before a treatment decision in the first line is drawn. RAS wild type left-sided tumor should be treated with anti-EGFR in the first line setting. BRAF mutation should be treated with triplet chemotherapy FOLFOXIRI plus Bevacizumab. And in the treatment sequences, anti-EGFR followed by anti-VEGF is the preferred treatment sequences for the left side RAS wild type. And anti-VEGF bind to progression, we have several anti-VEGF agents were approved by the progressions on containing regimen with similar efficacy profile, including Bevacizumab, aflibercept, or ramucirumab. And thank you.